I want to welcome everybody. Come on, John. I was waiting on you. Do you know Dr. Todd or Dr. King? Were they here when you were here?
Dr. King, ID?
Yeah. My name is Terry Davis, for those of you I haven't met. And today I'm going to give a grand rounds on rural health and rural health disparities. I realize in the 39 years I've been here on the faculty, I have gone to a lot of grand rounds in medicine, family medicine, peds, cancer. I've never heard a grand rounds on rural health or rural health disparities. And I think it's important that we do that. Also, when I teach, I like to team teach with an MD who practices every day what I'm talking about. So you can get a deeper dive, real life picture into what's happening in rural areas and what happens when they try to get consults or referrals here and we discharge patients back to them. So this is Dr. Sam Abshire. This is his wife, Camille. And they live in Haynesville. My first job here, I'm a clinical psychologist, and my first job was a behavioral scientist in family medicine. And Sam was a resident then, and I remember him. I thought he was pretty sharp. And then for 39 years, you've been practicing medicine in Haynesville? 35 in Haynesville and in Homer, in Claiborne Parish. And so you can get the population of all these little towns. His main clinic is in Haynesville. Is that downtown Haynesville, Sam?
That is downtown Haynesville, yes.
Okay, so you get a sense of where he and Camille live and where they're practicing. Sam, just out of curiosity, how many patients a day do you see?
On average, about 25.
25.
Which is on the lesser side for family medicine, rural family medicine. I practice more time-wise as an internal medicine physician than I do as a rural practitioner. Most of my colleagues see 40 to 50 a day.
So why is this talk relevant to you guys? So what percentage of our patients do you think we've discharged in the last 6 months come from rural areas in Louisiana? Give me a guess. 35? Anybody else? What about the residents? These are people you see every day. What percent come from rural areas, would you say, in Louisiana? Do y'all know where they're from? 75, well, that's closer. So in Louisiana, it's 59%. What about rural areas in Texas and Arkansas? 12%. So 71% of our patients that we've discharged and cared for in the last 6 months come from rural areas, only 21% from Shreveport-Bossier. Now, we used to have about 50%, but with the Medicaid expansion, a lot of those people have gone to Willis-Knighton. So maybe we'll get some of these patients back, but we care for a tremendous amount of rural patients. Does that surprise you? How many patients do you refer like a month or in 6 months? Are any of these your patients that you've referred?
Yeah, of course they are. On average, I probably refer one patient per week.
One patient a week up here.
And of course, with my colleagues seeing more patients than I do, it's more referrals from them. So a pretty significant number in the course of a year.
So from a town that has 2,000 patients, one a month, a parish with 16,000. So you might say, well, what do I know about rural health? Well, Connie and I have done a lot of research. These are our ongoing projects, and a lot of these projects are in rural areas. And so you can see that the stars are clinics. Oops, sorry, Sam. Okay. Clinics in Louisiana and Arkansas. These are family medicine clinics. That's where their residencies are in Arkansas. And these have to do with promoting colorectal cancer screening, transitions of care from hospital to home, weight loss, diabetes self-management. We did this cool project for the National Academy of Medicine calling drugstore pharmacists, mom and pop, and chain drugstores and clinic physicians and nurses to talk about what they're doing to promote flu and pneumonia shots with seniors. And then we're on a statewide research grant, LACATS. So these, and the color code on these maps, red means that approximately 30% of the patients that live in this parish or county are probably reading on about a 5th grade level. These people would have a hard time clearly understanding instructions on a prescription label. I don't know how they can handle your discharge instructions, but more about that later. So I was just very curious what your rural roots are. Let me tell you about mine. So I mainly grew up in Dallas, and I think that a lot of us, and I know that a lot of people at the NIH and the National Department of Health think we all live in places like this with resources that are available in places like Dallas, resources and jobs and education that's available here. But for the first 7 years of my life, I lived in San Saba, Texas. As you can see, it's ranching country. There's downtown San Saba. The population's probably been the same. That's what it is now. That's about what it was when I lived there. So I want to tell the medical students 2 stories about living in San Saba. First of all, when I was born, my family had to go to another town, 30 or 40 minutes away, because we didn't have a hospital in San Saba. So I was born in another town. Then when I was 6, I had to have an emergency appendectomy, and the family doctor did the surgery. There was no because there was no surgeon in town, and it was emergent. So this is life there. So Sam, where are you from originally?
I'm from Abbeville.
Abbeville. Just a show of hands, how many of y'all have come from towns that are less than 50,000, which the feds think, okay. How about anybody from small towns less than 10,000? Okay. And anybody that lived out in the country? James, you lived in the country?
20 people in my high school class, public high school.
20 people.
Across the river was 3.
So what are we going to do today? Well, we're going to talk about Louisiana and rural population health and healthcare disparities. I hope we develop a deeper understanding and accommodation to rural patients' transportation, navigation, and communication challenges in getting health care, especially here. Recognize problems rural physicians experience with us and other urban healthcare systems regarding communication with the doctor, consults, referrals, discharge follow-up, medication changes, and discuss strategy to improve collaboration with rural providers so we can work together to improve transition of care and population health. So, Sam, I was very curious. You were saying when one of your patients, if they don't have transportation, since there's no public transportation in Haynesville, how much do they have to pay to get a ride to see you, to come to Minden, or to come over here for health care?
Yeah, that's interesting, Terry. Probably a third to half of my patients actually pay privately for a ride. If they're coming in town to my clinic, it's $5 to $10. If they're going down the road to Homer, which is 12 miles, it's about $10, maybe 15. They go to Minden, that's 20, and to come here at LSU is $50 on average. And that's out of pocket. What I've always felt, and Camille and I have talked about this, what's so different from our habit is that if I needed a ride to Shreveport, I would call one of my church family, I'd call one of my neighbors, call one of my friends or relatives, and the issue of paying for transportation just never comes up. I mean, that's not at issue. It is very much at issue in rural America, well, at least for Claiborne Parish.
So if we want to see somebody back, I was talking to James Morris about this yesterday, and you pay attention to people's zip codes and where they're from, and I'm pointing them back, because if they've got to pay $50 or if they live 50 or 100 miles from here, it's going to be a huge burden just to come back for a checkup. So I I thought it would be interesting to kind of look at our population health. You probably know we rank 50th in overall health. You might not know that we rank 48th in health system performance, Dr. Powers, 49th in the slides you sent me yesterday in 30-day Medicare hospital admissions. So a lot of what's driving this is our behavior. We rank 49th in obesity, 46th in cardiovascular disease, cancer, diabetes, 44th in hypertension. Sam, do you see a lot of obesity, cardiovascular disease, diabetes?
Obesity, diabetes, hypertension, and COPD is us. That's who we are. We're not only poor, meaning the parish, we're not only poor, but when you start from there, then you have all these health problems added to that, and the equation is pretty simple. But although it's a simple equation, I don't see a simple answer.
Okay. And so COPD and congestive heart failure are the two main diagnoses that come back in to our hospital. And you see, okay, this COPD is the root cause smoking? Okay. So this is the Louisiana Department of Health. This was amazing to me. Okay, if you didn't go to high school here, 8th grade, there are 64 parishes in our state. Caddo ranks 48th and Claiborne ranks 49th among 64. We're in the bottom quartile of the state that's the worst in the nation. So we've got a lot of challenges. I guess if you're going to practice medicine in Louisiana or in Caddo or Claiborne, you always have a job. We've got really poor health. You can see who's at the top. A lot of the bottom is poverty and lack of education and a lack of jobs. And I'm going to ask Sam about that in a minute. So it's our demographics and our behavior, the root cause. That just hit me in the face. So in preparing for this, so wait a minute. Oh, I'm going, okay. Now, so you can see that Louisiana is worse than the U.S. and Claiborne is worse than the state average as far as poverty, minorities, basic literacy. Fewer college graduates. There are only 14% of Claiborne Parish are college graduates. They must think you and Camille are really smart. So, I think that's interesting because we probably hang around people that are not only college graduates but have graduate degrees, and to recognize this disparity. Smoking is higher, overweight and obesity. Sam, what is happening there? And no physical activity in the last 30 days. So Sam and I had lunch and we were talking, and I said I had this faulty belief that people in rural areas were very physically active. I had this vision of them working on the farm all day. And so what'd you say when I said that?
Well, I tried not to laugh, but I said you need to come visit.
So so why are they not working on the farm? What are they doing?
Well, truthfully, the large majority of them are basically doing nothing. I went on just curious, I went on a house call yesterday at noon just to kind of get myself prepped for this visit here. And I drove through a neighborhood, and I think it was the 12th house I came to that there was not a vehicle either on blocks in the yard or just sitting in the yard, and adults outside just roaming around visiting. It's really pretty disparaging at times.
So how does this manifest in your patients? They don't have jobs, and they're not busy. They're not doing stuff.
And basically, it's that, at least from my view, is that the population now is learning from the population obviously ahead of them. I mean, they're basically born into what they're doing now. So therefore, what would change the next generation of those? Poverty, is rampant. Unemployment is rampant. The major employer in Claiborne Parish is the state of Louisiana, primarily by virtue of the public school system. The second largest employer in our parish, and we're blessed to have a very, very nice hospital. The hospital is the second largest employer, and I think we have 141 FTEs. The third largest employer is the state penitentiary in Claiborne Parish. Y'all probably seen some folks from there. And then when Camille and I moved there in 1984, it wasn't that. The first thing was the oil industry, and probably secondly was the timber industry. Those are basically gone away.
So you talk to doctors in rural parishes that Connie and I have been working, that's happening everywhere. There used to be employment there, and they have moved out. And so if there's no employment in the area except the state, poverty rises unless you move. So one of the themes here is that there's some significant, striking differences with our patients who live in rural areas and people who practice there. And my goal is that we have not only an understanding of that, but we begin to accommodate better to that. So 1 in 5 Americans live in rural areas, which is green. And you can see Louisiana has a lot of green. And the federal government is all of a sudden realizing that this is a problem. They haven't been paying any attention to the needs of rural America. So rural residents tend to be older, poorer, as Sam said, less educated, underinsured, because most people have insurance through their employer. If you're not employed, you don't have any insurance. Limited job opportunities compared to those of us who live in cities. Geographic isolation, lack of public transportation, you heard a story about that, higher rates of health risk behaviors. Sam, why is that? Why are there higher rates of health risk behaviors there, like smoking and having a poor diet?
Well, I mean, basically, if you're not employed or you're partially employed, part-time employed, or you're living with someone that meets that definition, I mean, if you're sitting around, what do? Not me, I don't smoke, but basically you smoke, you drink, you play lotto, scratch-offs, you watch Dr. Phil or whoever's on television all day long, which I never watch. I hear it's pretty dramatic. And that's it. I mean, it's like this endless circle. I mean, it's like so very few people jump off that merry-go-round.
So barriers that we have discussed include distance to the primary care doctor, persistent shortage of providers, I'll show you a slide on that in a minute, and lack of access to specialists, limited referral sources for dental service, addiction treatment, mental health services, dietitian, ophthalmologist, preventive care services. So all of these are very common in urban areas, but not so common in rural areas. This is national data that no matter what the demographic, poverty is worse in the deep blue, which is rural areas, than it is in metropolitan areas. Metropolitan includes inner city also. So there's just a lot more poverty, and I think that's driving a lot of this. So part of the problem is not only things are worse in rural counties, but the disparity is growing with cardiovascular disease, cancer, unintentional injury, COPD, stroke. So Sam, you were telling me about unintentional injury. Sam also works the emergency room. How many shifts a month?
Maybe 80 to 100 hours a month.
Okay. And so tell me about car wrecks. Why are they 86% higher? Is it because they're driving more?
No, what they're driving are basically many times unsafe vehicles. They're driving impaired, either alcohol and or drugs. A lot of that is, guess what? Opioids, Schedule IIs. That epidemic is real. That's not just political. The roads in Claiborne Parish, I mean, unless it's a state road, if it's a parish road, it's not very well kept. we still have a lot of roads in Claiborne Parish that are red dirt or red dirt with gravel or partial gravel and old blacktops with holes. So there's a number of reasons. I was on a coroner's call only 2 weeks ago, Friday night, and the gentleman left Highway 2, which is a major highway, which is a nice, and for whatever reason, well, he was impaired, he was drinking, but he left the road probably at 110 miles an hour, according to state troopers, and hit a pine tree about 12 feet above the ground. And he's, I mean, kind of gruesome, but the only tissue that kept his left arm attached to his body was his joint capsule. I mean, we see that all the time, just really serious, terrible things.
So suicide is higher, particularly in men. Why is that?
Well, I can give you my view. I don't know the actual academic answer, but from my view is that men in our society still are looked at as the head of households, basically the income makers. Well, if you have no income, that doesn't do a whole lot for your ego, doesn't do a whole lot for your persona. So when you don't have a job and you're sitting around all day and you talking to other guys that don't have a job and they're sitting around all day, and you fall into that alcohol, drugs. I have a lot of amphetamines, a lot of meth in Claiborne Parish. Schedule 2s, it's the same vicious cycle. I mean, you just decide to, take it out.
So this shows you disparities in diabetes are increasing, but I could have put up a graph of heart disease, COPD, a lot of things. Those disparities are increasing. And one of the things about diabetes is there is just a lack of referral sources. If y'all diagnose diabetes, you send them to the dietitian, they have to go to the eye clinic, foot clinic, yada, 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 and y'all don't have that. So we've talked a little bit about mental health and drug challenges. So the rate of opioids abuse is pretty much the same in rural areas as it is in metropolitan, but it has a more devastating impact in rural areas. Fatalities are higher. Sam, do you think the emergency rooms are better equipped here to deal with drug overdoses or opioid overdose? Or tell me what's driving some of that.
Well, I think that, certainly the emergency rooms, I think, are better prepared because they have basically ER residents, fellows, ER staff. They have access to, I think, all the diagnostic equipment they need right there in the emergency room. Basically, for us, when we get opioid overdose, it's kind of like getting, somebody has cardiac arrest. I mean, for us, it's the ABCDs. And after that, I mean, what do we do with them? I mean, we don't have the facilities to detox folks. We don't have the facilities to, do counseling for the families that are pouring in there. That what's happened to Johnny? He's, this, that, or the other. So
where do you refer people? I mean, is there drug treatment in Claiborne Parish? Is there few mental health services? And one of the other things in rural areas, everybody knows kind of everybody else's business, and there's more stigma involved. So what is the referral when you discharge somebody from the emergency room?
I'm disappointed to say that the majority leave with whoever will come pick them up. There is no, if you're looking for the answer, Terry, like, well, we have, social worker who has them engaged in some, drug abuse, substance abuse evaluation 2 days from now, and they may stay in a facility or they may go into, some outpatient treatment plan. That doesn't exist for us. We don't have it. We have no mental health providers other than you look at one. And I'm certainly not that by training. We have no clinics to refer them to. Minden Mental Health is our closest referral source. We call LSU, and these guys here are overwhelmed. We try Willis Knight, and sometimes they can help us, sometimes they can't. What we found most often, and this is interesting, is that in the emergency room, every morning about 7 o'clock, comes over the fax about 7 or 8 psychiatric facilities across the state, from as far away as New Orleans, from almost to Mississippi. We have beds. We have male beds, we have adolescent beds, we have pediatric beds, and I look at that every morning when I'm getting off a call, and I'm thinking, wow, these folks are looking for patients. Why didn't somebody move over here? You'd have all you want right here. So it's interesting.
So there's no convenient treatment
zero.
facilities. So things are worse in rural areas, and they're even worse in the South. So this is heart disease, but you could put up this map with hypertension, COPD, a lot of things, that they're worse in the South. And so, like we said, it comes back to the behavior and the demographics. Smoking is twice as high in rural areas, severe obesity, physical inactivity. Sam pointed out to me, I put this picture up because he said, the highway may not be a good place to walk. There are a lot of places here, if you wanted to walk, you could walk. You could walk around this compound even. But it might be dangerous to walk on some of the highways.
Well, you mentioned accidents earlier.
Yeah.
I mean, why would you want to walk on a highway when
Somebody going 110.
Yeah.
Less screening for colon and cervical cancer. And one of the grants that Connie and I did at that time, these rural clinics, the screening rate for colon cancer was about 2 to 5% got screened. And there's lower HPV vaccination. So here's another map for you with obesity and physical inactivity, which is driving this. So one of the things I want to talk about at some point, and hopefully we can have more discussions, is what we can do to improve population health. If we say I can't do anything about poverty or population health, things will never change. So what are we willing to do to make an effort there and to work with people? So tell me what your patient challenges are. I mean, how does this manifest, all of this statistics, how does this manifest in your daily senses of who you see?
Well, the first thing is communication. It's three most important things in taking care of patients, in my view, are communication, communication, communication. If we cannot communicate with our patients, basically when they need to come to the clinic, why they need to come to the clinic, when they leave the clinic, what did we do for you today? Hopefully something positive. Did we change medications? Can you communicate with your pharmacist? Can you ask an intelligent question? Can you read the follow-up appointment card that you have? Can you read the referral sheet to go down to the hospital and get your x-ray? And how do you get there? Do you have a way to go now? Or like most of my patients, they go home because they didn't negotiate before they left home. They may have to go 10 miles down the road to get whatever diagnostic or treatment plan it is.
So I wanted to ask you something about this. As you can see, we have a lot more physicians per patient in Caddo, one physician to 860 patients, and in Claiborne Parish it's 1 to almost 3,000 patients. They're doing a lot worse with dentists and mental health providers. But you were talking to me, you said there are 3 drugstores in Haynesville, and 2 of them close at 6 o'clock at night?
Well, I think probably all, well, yeah, Fred's may stay open till 7, but the pharmacist may not be there.
Okay, and you told me...
So basically, it's, 6 o'clock, which is pretty late for, that seems probably early for you.
Yeah.
That's kind of appropriate for us.
Okay. And there's one grocery store, it's a Piggly Wiggly.
Right.
And I was reading a report from a student yesterday who was working with a patient in a rural area, and he had trouble buying healthy foods, and he thought the foods were more expensive at the only grocery store in town. What about Piggly Wiggly?
Well, I think what it is there, it's not the so much, well, it is so the health or the nutritional value of what someone walks into Piggly Wiggly for in Haynesville is secondary to what does it cost, what's on sale, what chips are on sale today, what generic cookies are on sale today, what generic soda water is on sale today. It's really the actual nutritional value is secondary. It's what is the
Cheapest.
financial availability.
So if we discharge somebody and they need home health care, can they get it in Claiborne Parish?
Yeah, we do pretty well on home health. We have the hospital has a home health, and then there are 4 or 5 other home health agencies, none in the parish, but those in adjacent parishes, and they do well. You may or may not know, the average home health nurse will drive over 200 miles a day. They call it windshield time, obviously. That's a lot of driving to see 4 or 5 patients.
So if we do surgery, say orthopedic surgery on a patient, a shoulder or a knee, and they need PT, where do they go for PT?
We have PT at the hospital.
Oh, at the hospital.
So if they can get there, they can get it.
Okay. But drug treatment, not so much, huh?
Not so much.
Okay. So I want to tell you about a couple of studies that Connie and I have done. So we got a grant from American Cancer Society to promote colorectal screening in rural clinics. So we know literacy is a problem. We know access is a problem. So we went in and we in-serviced with James Morris, the whole staff, and then we trained a designated person at the clinic to be an educator. We developed simplified materials, and we gave them an FOBT, the FIT kit. And if they didn't return it to the central lab in Dallas, Texas, we called them in 4 weeks and 8 weeks. And the study was a randomized controlled trial. You either got an automated call, which was very cheap, or a personal call. And so what did we find out? Well, we did great the first year. About 68% got screened, and there was no difference in an automated call and a personal call. And that's important for Ochsner and other health systems, that the automated call as a prompt was just as effective. And the reason 69% is and 67% are amazing is because the national rate is about 70%, and these clinics were not doing very well then. They didn't, when we did this study, none of them had an electronic health record, or if they did, they didn't know how to use it, and they didn't have quality indicators that were mandatory from HRSA. Sam, you're not a federally qualified health center, but do you have quality indicators as a rural clinic that you've got to meet with flu and new and colorectal screening?
Yeah, well, we are a certified rural health clinic.
You're a certified rural health clinic.
Kind of the first cousin of the federally qualified health clinics, and the answer to that is yes. It was minimal when we were just answering to the state, but in the last couple of years we've had just increased qualifiers for patient visits. Right now we just started a new one March 1st, and I can't tell you what they are, but it's 9 questions that patients are asked. These are Medicare age patients right now. They come in, they call them annual wellness visits. Visits is kind of a misnomer because the only time they see a provider is when we walk into the room, when the LPN is finished with her educational and questioning and get the answers to these 9 parameters, that we actually come in and sign off on it. And it's things like you've just mentioned. When was your last colonoscopy? When was your last mammogram? Have you ever had a mammogram? When was your last GYN or GYN exam or pap smear? Do you have any mental health issues? And there's a 9-question subset regarding depression and suicide risk. So everyone gets that, and that's great. It's just, what do we do with it?
Are we doing that in our clinics? Do the patients fill out the preventive health surveys? Anybody know? So the other thing that was different, before Medicaid expansion, colonoscopy wasn't feasible. Not only could they not pay for it, they don't have jobs, so they don't have private insurance, and GIs were not available. And now with Medicaid expansion, James Morris has let us know that they're sort of itinerant, instead of preachers, they're sort of itinerant GI guys, and they go to rural hospitals maybe once a month, once a week, to perform colonoscopy. And I don't know what the uptake is on rural colonoscopy. A lot of people don't want to have a colonoscopy, but you can see the challenge with the FIT is the second year, less than 50% did the test. It's only good if you do it every year. And the third year, only about a third. So here's another thing about these calls. The first year, less than half needed a call to prompt them. But by the third year, about 80% needed a call to prompt them, to remind them. Do y'all use automated calls with your
We
patients?
just started about 6 months ago. We use automated calls only for clinic appointments.
Is that working out? Has that improved?
It really has.
What's your no-show rate?
We're probably no-show rate right now of 10 to 12%. Before that was probably 20 to 25%. It really.
Are we still
it made a
30% on our no-show? Probably more. Okay. So this was a cool thing that Connie and I did. We got to call pharmacists in mom and pop drugstores and in chain drugstores and doctors all over the place, from Montana to New Mexico to Georgia to Maryland, to find out what they were doing. And the successful programs with flu and new, the clinic or the drugstore leadership viewed immunization as a part of their mission. They had a designated immunization champion in the clinic or the drugstore. They organized teams, tracked progress, offered incentive. And in rural areas, they built on the personal relationship with the patient, knowing not only the patient, but their entire family, that they could personalize information if the patient was resistant. Also, some of the Texas rural mom and pop drugstores were doing all kinds of cool community outreach. They had pop-up flu clinics at Friday night football games. So it's like, if you're going to immunize people, you got to get them where they are and make it convenient for them. And the other thing that I was impressed with in the rural clinics in New Mexico, if the patients were elderly and lived way out of town and they didn't have the vaccines, but the drugstore did, they would send them to the drugstore. And I know the drugstores get them before the doctors do, and that can be a problem. But what are y'all doing with flu shots?
Well, of course, we offer flu shots in our clinics primarily. And we have, in October, 2 Saturdays in October, we have, quote, free flu shot clinics. We just subsidize. There's not that many of them. The hospital service district helps us pay for those. And then we go out like to the football teams, like talk to the coaches, school nurses. We have some pretty active school nurses. They do a good job there. And then, of course, the drugstores. It always bothers me a little bit that Brookshire's or Fred's in August 10th or 12th this year, they had their sign out, we're giving flu shots. When I went to medical school here, our immunology was a little bit different. The vaccine, I'm supposed to only carries immunity for about 6 months, and if you get it in August, you're not going to make the flu season.
So that has been an issue nationally.
It's a financial issue for them.
Right.
Yeah.
So then I want to tell you, this is the last research project I'm going to tell you about. It's a transition of care from hospital to home. We did 40 national focus groups. Connie and I did rural focus groups. They visited 42 hospitals and did site visits. They surveyed 12,000 patients, 9,000 family caregivers, and 1,200 physicians. And here's what we found out, Connie and I found out from the focus groups. Patients felt connected to the primary care provider and they had confidence in them. They didn't feel like the hospital staff knew them or their health history and were less inclined to have confidence in them or to trust their discharge treatment plan. This is you guys. Physicians at hospitals are always different, they said, with each admission. There's no continuity. You don't see a familiar face. You don't know anybody. They don't know me, and they don't know anything about me. So most patients were confused when they left the hospital. Several didn't feel like they knew how to take care of themselves. I wasn't clear what was wrong with me or what did I need to do about it. They give you a big piece of paper with everything they did for you, and you take it back to your doctor. You can't grasp everything they're telling you. You're sick, and you're going to miss a lot. So do patients come to you after we've discharged them with questions about discharge plans or what happened to them?
Most of our patients, particularly those that have been hospitalized for several days, you're right, they'll leave with a packet, pretty thick packet. And many of them will just stop at the office before they ever get home, just drop in and say, does Dr. Abshire, Dr. Butler, or Angela, someone have time to explain this to me? I mean, literally, can you explain this to me? Why did they change my medicines? Why am I supposed to go back? Why do I have these tests before I go back? And I'm telling you guys, it's different out there. It's really kind of a compliment, but it raises a point when someone leaves this facility and they're going to have surgery by Dr. Sin in the Department of Neurosurgery, and they stop in my clinic and say, do you think this is what I should do? I mean, that's a big jump between family medicine and neurosurgery in a tertiary care facility, but that patient is asking me. And I remind them, I said, well, James, I sent you over there to Dr. Sin because I felt that you had this issue and that he could best. I know, but I just wanted to double check with you.
So there's the trust. So here's what these national surveys found. What do they like and how are we doing with this? They like it when we use empathetic language and gestures. Our body language is important when communicating with patients and their families. They said explicitly they like providers who sit down and are not rushed. What was amazing to me was what I found out is that fostered trust in the healthcare team and in the care you provide. They want clear, actionable information. They want teach back to confirm understanding. And they want to be involved. Not all. Many older patients just say whatever you think and then they come and ask you what you think. But increasingly, people say nothing about me without me, and that's what the American College of Physicians says. They like it if they're encouraged to talk and they're permitted to ask questions. And here's the deal. Who you call when you go home? Who do you call at 8 o'clock at night if you have a question about your medicine? Who do you call if you have questions? So anticipating and arranging for patient and caregiver needs at home is huge. So I'm going to ask you a question in a minute. Here's some hidden problems. When they get conflicting or unclear information here, different doctors or nurses tell you different things or use inconsistent terms. It provoked anxiety about the quality of care. It was frustrating and confusing and increased anxiety. There was not always a competent caregiver at home or sufficient resources at home. And then patients can feel abandoned and perceive that providers don't care about them. So here's some complaints about medication, and this was the main thing we heard over and over. They take you off of everything your PCP put you on. When they give you medicine, they didn't explain it. Insurance companies sometimes won't pay for the medicine. This is the national study the doctor put you on. Nobody asks if you can afford it. Then there was difficulty. The hospital said they had faxed the discharge information to the pharmacy, and the pharmacist said, in these little towns, I never got it. And caregivers were often frustrated with the timeliness of being able to pick up prescriptions. If you discharge somebody at 2 or 3, what if they get to Haynesville after 6? Do they have their medicine? Have we discharged them with the medicine? I don't know. Do we discharge them with medicine? Did they get it here before they leave? There's a pharmacy here. That's good. So we've talked a little bit, Dr. Abshire, about transportation, follow-up challenges. What are the, and you're talking about communication challenges. What about follow-up challenges, follow-up care? Is that you? How often do they have to come back here, and is that feasible?
The answer is, by default, I think most of the time it's me. And how they're scheduled or what they're scheduled to come back to this facility, I have no clue. Because unless they walk in and hand me a packet of materials, discharge materials, I have no clue. We get no feedback from this facility.
Would that be helpful if the primary care doctor got the discharge
Well, of course
instruction?
it would,
Okay.
yeah.
And that was something we heard in South Louisiana as well. So what are your challenges in communicating with us, with the providers up here? with consults, referrals, discharge. You told me that a lot of times it wasn't a referral you wanted, you just needed a consult.
Yeah. Well, we have a line in 3 minutes, and we have a hard line in 13 minutes.
Right.
So
Can you tell me quickly?
I can tell you quickly.
Okay.
Is that, you mind if I stand?
Stand
All
up.
right. Is that communication is not just between you and the patient, it's between you and me. You're the facility, you're the specialist, you're the ones that we look forward to for guidance. We're the ones that are sending our patients who trust us to you, okay? A problem that I had that's been perpetual, at least the 35 years I've been in practice, is that, and this used to bother me when I was a young doctor, and Camille can verify this. I would call to get a consult, send somebody, and the response I get more often than not is I was talked to like I might be a second-year medical student. Like I had no knowledge of what I was calling about. I had no clue. And that is very frustrating when you're trying to get a consult, you have a sick patient, sometimes they're in front of you, sometimes with family in the room. You're trying to get some help. The reason we're calling is we need help. If we knew what we needed, we wouldn't be calling. And so when the first response is kind of antagonistic, I mean, where do you go with that communication? Not very far and not very positive. And I'll say it, supposedly you hear that the electronic health record and IT is going to, super speed physician communication, aftercare and whatnot. That is absolutely wrong in my world. We did better when we had nothing but a telephone. It got a little worse when we had faxes. Now we have electronic faxes. I walk in on Monday morning, I have 300 or 400 electronic faxes waiting for me. Go answer that. I would just like to say, at this point, is that she hadn't got to the slide yet, and we're probably not going to get to the slide, is that I would hope that each of us would have come to medical school for a purpose of helping others. I'm not naive. When I sat on the third row and the third chair is still empty, and like when I came here and sat in this room, everybody went to the back, is that some of us, hopefully the majority, came to help patients, came to be a positive contributor to our society, to help those less fortunate than us. I'm not seeing that, guys. I'm not seeing that. I called recently. I had a 14 or 15-year-old with a closed head injury, loss of consciousness, whatever. I'm working in the emergency room. Cleared his C-spine, cleared his abdomen, cleared his head, got a CT. We do have a CT now, And I called to talk to a neurosurgery resident, and they asked me, well, have you gotten an MRI? And I thought to myself, I said, man, if I had an MRI right here at 11 o'clock on Saturday night, what would you do? Why would I need you? And that's the response that we really, really sets us off, is that this lack of communication, like, you're too busy and I'm too busy. Well, I'm busy. I'm just as busy as y'all are. My 4 peers who practice primary care with me in Claiborne Parish, we're all graduated from this facility, every one of us. 4 of us did family medicine residency with LSU, 1 did internal medicine. Okay? We know what medicine should be. We know how we were trained. But somewhere along the way, those wheels have come off about how we really feel, or how we should feel, in my view, about our patients.
So I want to let them ask you some questions in a minute. You have one more parting shot? No, okay. Okay, I want to tell you one other thing. Increasingly, all our patients are going to be asked to be in clinical trials. Connie and I went to St. Jude's. They have 1,600 patients. About 1,500 are put on a clinical trial. That's going to happen. And we are now not including rural patients or minority patients, but if precision medicine is going to work, we've got to have everybody, and we need the help of the primary care provider, not just with healthcare and population health, but with clinical trials. And what they want is more relationship. It's just what you're saying. They want a closer relationship. They don't have time to search the internet for clinical trials for your patients. and what they want is a relationship with us and a poop sheet that they can give to patients, and they are interested in closer ties with us. So anything you want to say about telemedicine, would that be helpful at all, or webinars, or what would help you being able to, I guess what you said, being able to pick up the phone and talk to somebody that was kind to you?
We tried telemedicine. They don't have to be kind. They just have to be professional, okay? I can do without kindness. I just like professionalism. We tried telemedicine for 3 or 4 years, and the problem was in our hospital is that none of us practice in the hospital, okay? We all have independent clinics. For me, I drive 20 minutes to get to telemedicine.
I got you.
How am I getting my patient there?
So if for telemedicine to work, the clinic has to have it, and more clinics or get more rural clinics and FQHCs are getting telemedicine, but it's got to be convenient for the provider and the patient. Getting to the hospital is not convenient.
I think a better word is functional.
Okay.
I don't think convenience is not not up there. It has to be functional. You have to have a provider and a patient, someone locally, a technician who can hook it all up. Then on this end, you have to have a consultant, and no doubt you'll have to have probably someone who can hook it up for you. Because if you're in clinic and you're waiting to have a consult with me, you're not going to sit there, I don't think, until I happen to get
Right, you got
on the
to
phone.
have somebody who can use it there,
If
and
they're
if there's
coordinated.
IT problems, you got to have somebody who knows how to do it.
Yeah.
So let me I want them to ask questions in a minute, but it's like one of the things that we need to do clearly is have a better relationship with providers as well as the patients. And here's my summary slide. Poverty, low literacy, poor health outcomes are the root cause of a lot of our health problems. The majority of our patients come from rural areas, and they experience barriers that we need to be aware of. We can improve our communication and patient education with patients. We can improve outreach to rural providers with easier consults, transfers, coordination of care, professionalism there, and CME. And I think we all can work together to improve population health. I want to mention 2 things, and then I want Sam to have the last word. Ochsner has something they brought up here called Eat Fit. It's not a magic bullet, but it will do a lot. It's a dietitian who did this in New Orleans and who's come up here to go to restaurants to get them to have some healthier choices. Out of New Mexico, there is something called ECHO, and it is a collaborative model of medical education and care management. It uses webinars with PCPs and specialists to increase specialty treatment in rural and underserved areas by providing PCPs with the knowledge and support, that's what he was asking for, they need to manage patients with complex problems. So one of the things I want y'all to, what I want to leave you with is, what are we willing to do? So Sam, you got the last word. Here's what you had framed.
Well, yeah, basically, this, I'm just going to mention where this is. This, to me, I found about 12, 15 years ago. It's from a valedictory deliverance at the
Bellevue College, New York College of Medicine, Bellevue Hospital in 1871.
and Dr. Oliver Wendell Holmes. This is a lengthy piece that he wrote. I would challenge you in your spare time to read all of it. It is what the Hippocratic Oath is these days. That's how I look at it. This right here. And says what it is, and the next sentence, I can't quote it, but the next sentence that goes in this paragraph is almost as profound. Basically, what my frustration is, and as I grow older and I'm getting nearer to retirement, and that's not going to be soon, I hope, is that I get disillusioned with what young physicians and medical students, and I have several medical students a year who rotate. I have freshmen for immersion and third-year primary care rotations and some senior electives. And, so over the years, I've kind of kept a little bit of a weak pulse on what goes on here at the medical school. And increasingly, the students are talking less about the patient and more about muddy sewers of politics, enchanted waters of, not literature, enchanted waters of financing. And that's what I'm hearing. Now, enough about that. We have 2 or 3 minutes. I'd be anxious, or I'd be welcome to have any questions from the audience.
What kind of questions do y'all have for a country doctor who sees our patients every week? Yes?
Not really related to rural care, but what kind of advice would you give us medical students right now?
Advice right now, and where are you right now? You're
I'm not third year.
third year? Well, if you want to do primary care, okay, now's the time to start looking. If you're called, and that's kind of what practicing in rural medicine is now, is a calling. It's less and less elective, and it's more, are you called? Do you fit? Can you live in this type of culture? Because our culture is a whole lot different than the Shreveport-Bossier culture. It's just that close. So if you're called to that, what you need to do is, the world is your oyster if you're interested in rural primary care. The world is your oyster. You can write your ticket. I don't mean that literally, financially or fiscally. I mean where you want to go, how you want to practice, what you want to practice. Independent, multi-physicians. Most everybody now gets employed when they finish their residency. All of that's available. The state of Louisiana finally, just in the last 2 or 3 years, has some very attractive opportunity regarding repayment of loans if you practice in a medically underserved area, and I think all but 7 or 8 parishes in Louisiana are underserved areas. Okay, our parish is particularly underserved, and so you get more bonus points if you go to these areas. What concerns me as much as anything is that of the 5 of us who practice primary care at our hospital, 3 of us over the age of 60, and the other 2 over the age of 50. There's no MD that's younger than 50 years old in our parish. And when I graduated, I wanted to practice medicine. I mean, that's what I wanted to do. I wanted to practice medicine, and I have been able to do that. Essentially, I could do whatever I felt I was competent to do. No one was looking over my shoulder and say, you can't walk into ICU, or you can't walk in an emergency room, or you can't do this, or you can't do that. You do whatever you think you're doctor enough to do, basically. So it's a good question. I'm glad you asked, and I'm glad somebody's interested in primary care. Any comments? Who's residents in here? Do we have residents? Do y'all? I'm curious. Do y'all talk to rural physicians? Do y'all receive consults on whatever service you're on?
Usually
No?
for transfer.
I'm sorry?
Usually for transfer.
Usually for transfer. Okay.
Sometimes for discharges, if we're trying to get someone out, I'll ask them who the primary care physician is, and we'll look up the phone number and give them a call and say, we're planning to discharge with these medication adjustments. I'm going to try and send a discharge summary, but I was also hoping to leave a message with them.
Yeah. You're a rare physician, because that happens rarely in my life. Okay. That's what we'd like to see. I still contend that a 2 to 3 minute conversation is worth reams of paper and discharge summaries. I still believe that. So I'm never, anytime I'm practicing and I get a call from a physician, I leave the room and I go to the phone. I excuse myself. Our patients understand that we're busy. I mean, they're in a busy waiting room. They hear my nurses. They know what we're doing. Excuse me, I have to go to the phone. Oh, yeah, fine, Dr. Abshire. It's good. Take your time. They understand that. But you got to want to go to the phone. So, anyway.
Dr. Abshire will stay around for a few minutes if y'all have questions, but let's give him and his wife a hand for